Hello, everyone. My name is Sarah Lackowski, and I'm a clinical dietitian at Northwestern Huntley Hospital, predominantly covering the intensive care unit. Thank you for viewing my poster board presentation regarding our transition to a standard fiber-free formula in the ICU setting. To start, I would like to provide a little bit of background information on what inspired my data collection. The American Society of Parenteral and Enteral Nutrition guidelines suggest using a standard polymeric formula when initiating enteral nutrition in the intensive care unit setting, as well as avoiding any routine use of all specialty formulas in critically ill patients. Our current practice has been the routine use of peptide-based formula for our intensive care patient population. The purpose of this data collection is to transition from the routine use of peptide-based formulas, or in our case, Vital AF 1.2, to a standard polymeric fiber-free formula, Promote 1.0, and to monitor and evaluate the tolerance of our ICU population, which not only aligns with recommendations placed by ASPEN, but also aligns with the system goal of fiscal stewardship. This data collection was completed over 1 month's time based on selective inclusion and exclusion criteria as listed below. The consultation process, nutrition assessment, and monitoring completed by the dietitian and interdisciplinary team remained the same. The only change implemented was utilizing Promote without fiber, the standard formula, in routine place of Vital AF 1.2, our peptide-based option. Patients were monitored daily for tolerance, and of the 11 patients who had met the original inclusion criteria, 9 were deemed to have tolerated Promote without fiber with no observed complications. Of the 2 patients who required transition to an alternative formula, one was due to the development of hyperkalemia, and the other required transition to a peptide-based formula due to gastric residual volumes greater than 500. When looking at the financial analysis of the product, it was apparent that this change of formulas would not only better align with best practice, it would also be very cost-effective for the organization. There is a cost difference of $7 between the 2 products. Approximately 65 liters of formula were used in this data collection, and that can be projected to a cost savings of around $5,460 annually. So to conclude, the results of this data collection reveal that not only did greater than 75% of our patients tolerate the recommended best practice, the cost savings can be greatly beneficial as well. Thank you again for joining me on my poster board presentation today.